My name is Isabel Griffin. I'm an epidemiologist in CDC's Office of Blood, Organ, and Other Tissue Safety. We also go by the name Boots. I'm sure many of you have worked with us. Our office is tasked with investigating infectious disease transmissions from donor to recipient through blood product transfusion, solid organ transplantation, and tissue implantation. Today, I will provide some historical context on transfusion-transmitted infections, or TTIs, and share what we're doing to improve hemovigilance in the United States. Transfusion-transmitted infections, or TTIs, can be severe and result in death. The problem is that TTI surveillance in the United States is inadequate. Compared to hemovigilance programs in countries like the United Kingdom, France, and Canada, where hemovigilance reporting is mandatory, reporting TTIs to CDC is voluntary. In the United States, there is no requirement for transfusing hospitals to report transfusion-related adverse events to CDC. And for nationally notifiable pathogens, transfusion history questions on the case report forms are not required, and this data is often missing from data transmitted to CDC. This lack of TTI surveillance leaves a major gap and an opportunity for a pathogen to emerge in the blood supply. And we've seen this in the past. In June of 1981, CDC published an MMWR describing a rare pneumonia in 5 young men. The disease went by many names, but we now know it as AIDS. At the beginning of the outbreak, it was unclear how the disease was spreading. It was suspected to be through sexual transmission, primarily among men who have sex with men, or MSM, or those who have sex with MSM, but another transmission route soon appeared. Hemophiliacs were being diagnosed with AIDS at an alarming rate, but they didn't have typical risk factors, just frequent transfusions of factor VIII, a clotting product produced from plasma donations. By December of 1982, several MMWRs describing case reports of HIV among hemophiliacs had been published, but it was an MMWR describing a 20-month-old infant who developed AIDS after receiving blood transfusions that provided the hemophilia community the strongest evidence that there was an issue with the blood supply. The hemophiliac community demanded that something be done. A month later, in January of 1983, CDC hosted a meeting with partners in the blood community to address this growing concern over the safety of the nation's blood supply. During this meeting, a CDC official, Don Francis, notoriously asked industry, how many people with hemophilia have to die? Is it 3 enough? Is 6? Is 10? Is 100 enough? To prevent this, this meeting brought up the same issues in blood safety that we have today, how to strike a balance between the theoretical recipient risk, product availability, cost of screening, and commercial interest. Unfortunately, this meeting produced no recommendations or changes. As early as 1983, there was evidence to suggest that HIV contamination of the blood supply might have been prevented. The hemophilia community demanded a government investigation into the events that led up to the epidemic. The Institute of Medicine, IOM, of the National Academy of Science convened a public hearing to identify the institutional determinants of HIV/AIDS epidemics among U.S. hemophilia patients. In 1995, this committee published 14 recommendations, 2 of which were for CDC. The first recommendation was that federal agencies must understand, support, and respond to CDC's responsibility to serve as the nation's early warning system for threats to the health of the public. The second recommendation was that the Public Health Service within CDC should establish a surveillance system to detect, monitor, and warn of adverse events in recipients of blood and blood products. This IOM report was considered a turning point in blood safety. For decades, federal agencies have worked together to provide oversight and monitoring of blood safety in the United States. The US FDA has direct regulatory responsibility for blood and blood products. This includes the license of blood components, derivatives, and donor screening tests. FDA also receives reports of transfusion-related deaths via MedWatch. The National Institute of Health, National Heart, Lung, and Blood Institute provides funding for basic and translational research related to the availability, efficacy, and safety of blood products and the development of alternatives. The Centers for Disease Control and Prevention is responsible for conducting surveillance and detection of public health risks related to blood. CDC works with federal partners to determine whether safety measures are needed. CDC and our Boots office have led many TTI investigations since 2015. These include arboviral infections, bacterial contamination of platelets, parasitic infections such as malaria and arboviral infections, including some very severe infections like West Nile virus and Cache Valley fever virus transmissions. Many of these investigations have resulted in policy changes and updates to donor screening recommendations. Federal agencies have worked together to identify donor deferral criteria to exclude donors with infectious disease risk factors. And today's blood donor history questionnaire asks about specific risk behaviors, such as injection drug use or recent tattoos, that may put somebody at a higher risk of having an infectious disease. Since the 1970s, serological assays targeting virus-specific antibodies and antigens have been effective in identifying transfusion-transmitted infectious agents. Recent implementation of nucleic acid amplification technology, or NAT screening, for HIV, hepatitis C, and B have also greatly reduced the risk by reducing the window periods for donations, as evidenced in Part A of that figure. NAT screening has also emerged as the preferred option for emerging pathogens like West Nile, Zika, and Babesia, as these NAT tests can be quickly developed and deployed within several months. However, NAT screening is more expensive, as shown in the middle figure, and if you look at Part C of this figure, there has been a constant need to reevaluate the risks of emerging pathogens to the blood supply for the past several decades. Some of these emerging threats in red, such as West Nile and Babesia, are true public health safety threats. In response to IOM's call for action, in 2010, CDC began operating the National Healthcare Safety Network Biovigilance Component Hemovigilance Module, a voluntary passive surveillance system. The Hemovigilance module serves as the only national surveillance platform for recipient hemovigilance that is available for use by all healthcare facilities in the U.S. performing transfusions. Remember our list of TTI investigations? None of these were reported officially through the Hemovigilance module, and it's likely that serious TTIs may have gone unrecognized and continue to go undetected. As a result, we are modernizing hemovigilance efforts to rapidly and systematically identify emerging pathogens transmitted through blood transfusions. But strong collaborations are needed with healthcare facilities, blood banks, and transfusion services to systematically, 1, identify pathogens of interest in a patient receiving a transfusion, and 2, notify CDC. We also plan to work closely with health departments and healthcare facilities to complete an updated TTI investigation form. For the past 15 years, CDC's NHSN Hemovigilance module has monitored transfusion-associated adverse reactions, including acute hemolytic transfusion reactions, acute lung injury or TRALI, transfusion-associated circulatory overload, TACO, and transfusion-transmitted infections, as well as a number of transfusion-related incidents and errors and monthly denominator data describing the number of transfusions at a facility level. Participation in the module was and is voluntary, except for in the state of Massachusetts, which mandates reporting to the module. Version 2.8 was robust in data collection fields and quality, but not so much in capturing a robust representative data set. Over the past year, CDC has been working to streamline reporting, modernize data collection efforts, and reduce the burden of reporting to focus primarily on elements with the highest public health priority. We have gone from 20 unique reporting forms to only 4. For those familiar with the module, you will see that many data elements are being retired to shift the focus of the module to the rapid identification of transfusion-transmitted infections and acute transfusion reactions. Some of you may have noticed that several of our pathogens of interest in the footnotes on the last few slides include those that are nationally notifiable, meaning health departments report these to various SME teams at CDC. And some of this reporting may include transfusion history of the patient, but that this is not a required field in most case report forms. And you'll also see that many of these pathogens are not nationally notifiable, so there isn't necessarily a reporting pathway to detect these on a nationwide scale, other than voluntary reporting to the hemovigilance module. So here's what we're planning. We will provide healthcare facilities with our pathogens of interest list, a list of pathogens known or capable of being transfusion transmitted. Facilities will use those as a flag. We'll use those to flag a laboratory result. The hospital epidemiologist, or ICP, will receive this flag and determine whether the patient has received a transfusion in the prior 30 days. If this patient meets both criteria, having a pathogen of interest and a transfusion in the prior 30 days, then this would trigger the hospital epidemiologist, or ICP, to notify CDC via the NHSN Hemovigilance Module new TTI Rapid Alert Form. CDC will use this report to notify the health department to begin working on a TTI investigation with the healthcare facility. The health department and the facility will be able to simultaneously complete this investigation form in the module. CDC staff will review these reports daily and follow up with the health department and/or facility if a public health response is triggered, for example, if an implicated product was given to more than one recipient. In the event that TTIs were to become nationally notifiable or mandatory reporting for a specific state, the state also has the option to build out the TTI investigation form in their surveillance system, and CDC can work with the health department to electronically transmit this data in real time if there's interest in this option. This is what the new 2-question TTI Rapid Alert form will contain. It's straightforward and simple. The goal is to enable facilities to rapidly alert CDC that a TTI investigation is taking place. This is also to quickly alert the health department of a potential TTI investigation, so the health department can reach out to the facility to help with the investigation. The TTI investigation form has also been expanded to include additional details concerning laboratory tests relevant to the investigation and epidemiologic risk factors that may rule out exposure to the pathogen through the transfusion. The investigation form also contains an updated components detailed section or table which collects more detailed information about the transfused components, such as ISBT code and test results, to assist with traceback efforts. The form will continue to use CDC's standardized case definition, imputability, and severity criteria for TTIs. And lastly, new sections capturing facility and CDC investigation notes will be used to help communicate between partners during TTI investigations. As of March 2025, 380 facilities in the United States are actively enrolled in the module, of which 75 are in Massachusetts, where reporting is mandated. But most states only have a couple facilities enrolled. For example, Florida only has 6, and West Virginia only has 1. Of note, these are just facilities enrolled in the module. Not all of these have consistently reported data. For example, only 61 or 16% of enrolled facilities have submitted their annual facility survey that was due in June. And as far as TTI reporting, only 3 TTIs have been reported to CDC this calendar year. But again, reporting TTIs to the module is not mandatory. We believe that we need to increase enrollment efforts to include another potentially 4,000 eligible transfusing facilities in order to capture robust TTI surveillance data. Ultimately, we need your help. While a mosquito bite or tick bite may be more likely, if your patient hasn't left the hospital in 3 weeks, then it may be a good idea to ask about transfusion history. And also, please ask your NHSN facility administrator to consider adding the biovigilance component to help with our reporting. Thank you for your time. If you're interested in enrolling in the Hemovigilance module, you can send an email to the NHSN help desk with Hemovigilance in the subject line. Thank you.